Well, good afternoon or good morning, wherever you are. Welcome to today's webinar. We're excited to have Team Alice presenting Leveraging Tragedy into Action. This webinar is sponsored by the US Deprescribing Research Network with funding from the National Institute on Aging. My name is Jennifer Chia. I'm a geriatric palliative care physician at the University of Massachusetts, and I will be your host today. I'm joined by Dr. Ken Bookvar from Icahn School of Medicine in New York, who will facilitate questions at the end of the session. But before we get started, I just want to cover a few technical details. Due to the number of registrants for today's webinar, we've placed your phone lines on mute to reduce audio feedback. So unless you are logged in as a host or panelist, your line is muted. However, we welcome and encourage audience participation using the Q&A feature on the Zoom webinar software. When you would like to interact with the presenter, please click on the Q&A icon bubble on the bottom of the toolbar and type your questions in the box. If you would like your question to be anonymous, you can check the anonymous box before sending. Hosts will acknowledge the questions during the final 15 to 20 minutes of the webinar. If you have any technical issues or logistical problems, we ask that you submit those using the chat box and select the co-host, Jonathan Norton, to chat privately. Please make sure you're identified either by name or participant ID so that our webinar host will be able to help troubleshoot any problem you're having with the audio or any other issues. Now we'd like to extend a huge thanks to our technical support team, Jonathan Norton at Johns Hopkins and Melinda Spar at UCSF and Gabrielle Schiller at Mount Sinai, who do the amazing work behind the scenes to make this all happen. And now without further ado, I would like to introduce our today's speakers, who are the team leaders from Team Alice. First, we have Mary Brennan-Taylor, Vice President of Programs at the YWCA of the Niagara Frontier, who's a community activist with a passion for patient and victim advocacy. Following the death of her mother, Alice Brennan, from a medication error, Mary embarked on a 10-year campaign to bring the patient voice into the schools of medicine, nursing, pharmacy, and physical therapy. A University of Buffalo Department of Medicine adjunct research instructor, Mary volunteers her time as a monthly lecturer in the medical school and serves as a founding member of Team Alice, a multidisciplinary team focusing on deprescribing and medication safety for geriatric patients. Mary also volunteers her time as a patient and family engagement advisor for Eastern Niagara Hospital. Along with Mary, we have Dr. Ranjit Singh, an associate professor of family medicine and director of the Primary Care Research Institute at the University of Buffalo. His research interests are in medication safety, implementation science, and health information technology. He is co-lead of Team Alice. And joining both of them is Dr. Robert Wahler, clinical associate professor of geriatric and palliative care pharmacy at the University of Buffalo School of Pharmacy and Pharmaceutical Sciences. Bob is a co-leader of Team Alice and director of clinical pharmacy services at Niagara Hospice. He is currently co-primary investigator on a series of projects supported by a grant entitled Community-Based Participatory Research for Reducing Medication Harm Among Retirees, funded by the Retirement Research Foundation. With further ado, I'm going to hand this over to Team Alice.
Hi, thank you so much for having us. Bob and Mary and I have the pleasure of representing Team Alice here. It is a large team, and we want to acknowledge all of their efforts. And you can see our website is listed at the bottom. You can learn more about the members of Team Alice there. I'm going to start with an overview, which, oops, sorry, I should start with disclosures, nothing to disclose. Overview, we're going to start with Mary, who's going to tell Alice's story. Alice was Mary's mother, so we're going to hear directly from her, which is very powerful to hear from someone who's experienced this type of event. After that, we'll follow up with an evolution and mission, meaning how did we turn this tragedy into Team Alice? And Bob will talk about the mission of Team Alice. Next, we'll focus on stakeholder engagement strategies, and we'll give 2 examples of projects which engage with 2 different kinds of stakeholders, and that will be the bulk of the discussion. And then we'll finish up with some reflections from Mary on how her tragedy has been leveraged and how we hope to continue leveraging this to good in the future. So I'm going to introduce Mary now. It's my pleasure to introduce Mary. I've known Mary for a long time. In fact, Mary reached out to us shortly after these tragic events. And it was clear from the beginning that her mission was to have some good come from this. And she had other options, right? When something like this happens, you can pursue punitive action, you can try to get some kind of compensation, or many people would have just kind of disappeared into the background. But Mary decided that this was something that she needed to do for her mother, and that could benefit tremendously the healthcare system, and those of us who are in the healthcare system have a lot to learn. So she decided to make it her mission to share the lessons from Alice's story. So I'm very grateful that she does this. I will talk a little bit afterwards about some of the things we've done together that have really been impactful. But without further ado, let me ask Mary to share Alice's story.
Thank you. Thank you very much, Dr. Singh. And thank you especially to all of the participants for spending part of your afternoon with us to discuss the life-saving importance of deprescribing when viewed through the lens of tragic and preventable loss due to polypharmacy, medication error, and a host of other never events. I only wish I had known about this concept when my mother needed it the most. I would like to introduce you to my mom, Alice Brennan, a feisty, social, and engaging 88-year-old who nailed all of the 8 activities of daily living, including living in and maintaining her own 2-story home, driving her own vehicle, managing the few meds she was on at home that included a medication for hypertension, a blood thinner, and an eye drop to prevent glaucoma from advancing. She shopped for and prepared her own meals when she wasn't eating with our family, did her own laundry, managed her own finances down to the penny, and had an extremely active social schedule. I'd like to compare her to a cross between Carol Burnett and Lucille Ball, if that gives you any idea about her irrepressible vibrancy and humor. That is, until her tragic and profound encounter with a profoundly dysfunctional healthcare system. The cascade of medical errors began before she was even admitted to a hospital as an inpatient. Let me direct your eyes, please, to the upper corner for July 3rd. In my opinion, that was the sentinel event that caused a lethal domino-like effect over 48 days. It was at this time that Mom went to a community emergency department during a holiday weekend asking for something to ease the pain in her neck and back, and be careful what you ask for. Her primary care physician's office was closed, and she had many picnics and parties to attend and didn't want to have this pain interfere with her plans. Unfortunately for her, she was given something. She was given something that should never have been prescribed for an 88-year-old, the muscle relaxant Flexeril. She was given the script, had it filled at her local pharmacy, and went home. And after taking a shower and moving around a bit, she was a little bit more limber, and she felt better. So she never took the Flexeril. It was not until we went to her neurologist a few days later for a routine checkup that we were schooled on the dangers of Flexeril for someone Mom's age. The neurologist, who had been seeing Mom for a few years since she had had a TIA, instructed us to dispose of the medication properly and never take it again. He gave us a crash course on the Beers criteria, and we thought that was the end of it. A few days later, Mom was experiencing pain and swelling in her right leg, and we went to her primary care physician, who referred us to an orthopedic specialist, believing she was suffering from gout. The orthopedic specialist agreed, but said that he needed to admit her to a local hospital for tests. She was admitted, tests were conducted, and it was determined that she was suffering from pseudo-gout. While hospitalized, Mom was under the care of a hospitalist because her primary care physician had given up privileges for working out of the hospital. And this particular hospitalist believed that she should be discharged to a rehabilitation facility for physical therapy for a week to 10 days, roughly. This occurred on July 17th. I'd visit her twice a day, both when she was in the hospital and when she was in the rehab facility. On the 29th, which you'll see that box in yellow as well, it was 16 days after her initial hospitalization. I stopped by to see Mom on my way to work, and I found her hunched over in a wheelchair out by the nurse's station. She was lethargic, she was nauseated, but most alarmingly, she was having violent hallucinations. When I asked the charge nurse, was Mom given something inadvertently? She said, no, I don't believe so. So she showed me the Mom's medication list. And there on the list, and if you're guessing where I'm going with this, there on the list was the medication that we were warned against. There on the list was Flexeril that Mom had been given 3 times a day since the 13th of July. So at this point, since she had been discharged from the hospital, on the discharge list was this list for the rehab facility, and they continued to provide her with that. I explained the warning that we had received from the neurologist and asked if they could please stop giving her this dangerous medication. It was stopped, but suffice it to say, the damage was done. What followed was a terrifying downward spiral from the adverse reaction she was having to Flexeril, and it included an unsteady gait, a depressed appetite, ongoing violent hallucinations, urinary retention, and profound lethargy. My once vibrant mother, remember the photos that I showed you, earlier in this presentation, was now experiencing falls, multiple healthcare infections, including MRSA, C. difficile, a UTI, and VRE, and terrifying hallucinations. She was returned to the hospital to deal with all of these complications, and at one point, the hospitalist decided that it was best for Mom to be transferred to a psychiatric facility. And when I refused, she was then prescribed a whopping 26 various medications, most of those antipsychotic meds that were also listed on the Beers criteria. So if you were to take a look at August 13th, right in the middle of this cascade chart, that was at that point when we realized, that things were continuing to spiral downhill. I contacted the head of geriatrics for the University of Buffalo to request a special consult. And when he went in to examine her, both a physical exam and looked at her charts, he met with me after and he said, Mary, your mother is suffering from about the worst case of polypharmacy I think I've ever seen. And if she's going to stand a chance of recovering, she's going to have to be removed from the majority of these medications back to just the few that she had been on. So again, the whole concept, I guess this was in essence the plan for deprescribing. But by then, the damage was irreversible. She was dying from the combination of polypharmacy and healthcare-acquired infections, and instead of dancing at her high school reunion, she was transferred to hospice care 48 days after this began. So, Dr. Singh, if you could advance. So this is the tragic and heartbreaking face of medication error. Polypharmacy, HAIs, and embracing the concept of deprescribing, in my humble opinion, would have saved my mother. Thank you.
Thanks, Mary, for going through that. I know it's hard for you to relive the event, so I appreciate you doing that. And as I said earlier, you do it for a very good reason, which is that you can inspire others to learn from the various lessons. And I want to say that, as I mentioned at the beginning, Mary's been working tirelessly to spread the word. This slide shows some of the things that Mary's been doing. She's been giving presentations at the national level to advocate for change. Some of that has been around medications, some of it has been around healthcare-associated infections. She's been tirelessly teaching with various types of learners. I've had the fortune of partnering with her to teach medical students, and we've taught more than 1,000 medical students over the last decade. Mary also wrote up a reflection piece in JAMA Internal Medicine, which was published in 2015. So for the first several years, Mary really put her efforts into a combination of teaching or education and advocacy work. And these are, if you will, the origins of Team Alice. But subsequently, as Bob will explain on the next slide, we wanted to leverage this experience into a research program. And so I'll let Bob explain that.
Yeah, one quick aside, Mary, I've heard you tell this story multiple times, and it still gets me. I still feel the emotion from you. So in June of 2016, Ranjit and I basically got back together again. We had done some work in the early 2000s on medical resident training in geriatric safety. And I then learned of Alice's story, and in a number of discussions, we decided, this is something that we can, work through and work with, and give us inspiration as we develop this team. The team that we developed continued to grow, and we attracted not only fellows within the Primary Care Research Institute, but students from family medicine and geriatrics nursing, and more recently social science, epidemiology, and human factors engineering. And I apologize to our team members who are on. We have so many of them now. We decided that if folks want to see everybody, you can look at the roster on the website. I do want to quickly note some successes out of our team, because we're very happy, and we realize part of the success of the team has been because it is a team, and we work together well. I note one of our pharmacy students. He was my mentee in pharmacy school, and well, he's developed through pharmacy school, graduated, did his residency, did a fellowship, and he's now on faculty with us at UB. One of our other team members was a NERSA fellow, and she had to leave us because she was then appointed dean of a local school of nursing at a local college, and one of our other members was a medical student who has now not only graduated the medical school, he graduated with research honors, and he's beginning his residency in the Western New York area. So luckily we can keep him with our team. Over that same time in 2017, we developed the Deprescribing Partnership of Western New York, which has a number of community stakeholders across the health system. I'll describe that a bit more in detail in a little bit. And then in the spring of 2018, the Elder Voices were also established, and Ranjit's going to talk about that. And one of the touch points that we always have is our raison d'etre. Why are we here? What are we doing? And we keep the phrase, and we often say this within our meetings: how would this save Alice? What we're doing, how would that have affected her? So we through this process, we basically over these past 4 or 5 years have met either weekly or bi-weekly. So we've had a lot of discussions as a team, and out of that we've developed our mission statement, and it basically is to protect seniors from medication-related harm across the continuum of care by a 3-pronged approach. So our first one is to conduct research. What type of interdisciplinary research, and not only to conduct it, but to disseminate it, and how would that protect seniors from harm due to medications? We've continued what Mary and Ranjit have started with interprofessional education, and we try to reach out, and UB has done a great job in IPE, and we bring together not only health care schools within our university, but other disciplines as well. And outside schools come in to listen to the story of Alice and to learn from it. And obviously, through listening it, there's more than just the polypharmacy pitfalls that occurred. And then our last aim is advocacy. How are we going to change things? And we want to take this all the way up to the national level, not only with government, regulatory, health plans, and other organizations. And this is the one that, you know, we haven't done as much yet as we want to, but that's because we're building. You know, aims 1 and 2 are what we're really building on, so that we can and get to this last statement, which is to leverage these 3 synergistic approaches to make a lasting difference.
Thank you, Bob. So building on what Bob said and what Mary described, Team Alice's mission includes research, education, and advocacy. And I want to start by talking about how we think about deprescribing. If we think about what happened to Alice, Alice met with her provider, and the provider said, you should stop taking cyclopentazepine. It turns out she wasn't taking it, which was good. But that's when deprescribing happened, when the neurologist said to Alice, stop taking or don't take the cyclopentazepine. So that's what we call provider-driven deprescribing, because the opportunity to deprescribe was identified by a provider. And that's what most published deprescribing research has been about until recently. And so that's important, and we want to contribute to that. We also want to acknowledge patient-driven deprescribing, and we put a lot of emphasis on that because we think that's a relatively new area. Some people I know have been working on this, and in fact, I saw a presentation by members of the US Deprescribing Research Network, Cynthia Boyd and Elizabeth Bayless, at a conference last year, in which they were talking about patient-driven deprescribing. We also are pursuing that aggressively, and I'll be talking about a project in that domain. Bob will be talking about a project in the provider-driven deprescribing domain in a minute as well. But coming back to what happened to Alice, there was a deprescribing event which was provider-driven, in which a decision was made that Alice will not take the cyclopentazepine. The problem was that that decision did not stick, right? There was no way for that, at that time in that system, there was no way for that decision to be shared across the system, which is why this big outer circle is so critical. The cross-system deprescribing capability is something that was missing and could have saved Alice. So we're very interested in pursuing and developing that. I'm not going to talk much more about that today, but that's an important part of our mission as well. So this is how we view the deprescribing challenge, and this is, in a sense, this overview is our strategic plan of how we want to tackle it. But our orders for today are to talk about stakeholder engagement. So let's talk about a little bit about stakeholder engagement in the context of this. So we have 2 main stakeholder engagement strategies. One is called the Team Alice Elder Voices, which Bob had already mentioned. It was a group that we formed, and I'll be talking more about that at length. This team is a community stakeholders, patients and caregivers. I show on the diagram here that their main role is in patient-driven deprescribing, but the reality, of course, is that they should be informing our work in all of these areas. The same goes for the other stakeholder group, which is the Deprescribing Partnership, which is a group of healthcare providers and members of and representatives from the healthcare system, which Bob will talk more about in a little bit. We show them here as their main focus being on helping drive the provider-driven deprescribing work. But the reality, of course, is both of these stakeholder groups are important for all of the work. Let me just expand a little bit on the strategic plan, which, as I said, has these 3 domains. And so this, I just quickly mentioned in this diagram that we have developed plans under each of these. Bob, as I said, will be talking about provider-driven deprescribing a little bit later. I'm going to move now to talk in depth about the patient-driven deprescribing work. So let me talk about that. So the main goal there is here for us is to arm patients and caregivers to protect themselves in two ways. One is to identify risky prescribing. And the other is, once they've identified that, is to advocate for themselves across the system. So I will talk to you now about a project that we currently have that's funded, that we're about 1 year into it. It's on the development of video animations to encourage patient-driven deprescribing. It's funded by RRF Foundation for Aging, which you might know it under its old name, which is the Retirement Research Foundation. This project will develop and also do a little bit of pilot testing on these videos. But I'm going to talk mostly today about the development process and how we engage both of those stakeholder groups in that development process. And the driving question again is, what would have saved Alice? So this slide is just to give you an overview of the process of developing these videos. So I'm going to start by saying that we use the methods from community-based participatory research, or CBPR. Now, some CBPR purists on our team felt that it might be technically not correct to say that we're using full-blown CBPR, because CBPR has 10 principles that need to be followed, and we maybe didn't catch all of them. But I think it's safe to say that we attempted to follow principles of CBPR, or were guided by principles of CBPR as much as possible. We did this in collaboration with a local group, or rather with some guidance initially from a local group called the Patient Voices Network, which is a network that formed to help address health disparities. It's a network of patients who guide the development of research projects locally, and we wanted to learn from them, how did they go about setting up this stakeholder group. And so we learned a lot from them. One of the things we learned from them was that one of the best ways to start a group was to start with one project. The goal of forming a group, the Elder Voices group in this case, is to be long-standing and have a role in multiple projects. But we wanted to begin by engaging them in one project. The process of developing these videos then, if I go into that now, started off with key informants. I'm using this jargon, key informants, because that's a research term, but what I really mean is Alice's family. So we started off with this, the way this project got started, in fact, is when Alice's family said, there are a lot of lessons from Alice's story. Maybe short videos is a good way to put them together in a way that can be shared. So we started by asking them to develop scripts of videos, and they came up with themes for 3 different videos that they thought would convey the messages of lessons from Alice's story. And so let me just go through this schematic to show you the steps that we wanted to follow. And then after that, I'll talk about the role of the various stakeholder groups in these steps. So the initial step was to have scripts that were written, as I said, by Mary and her husband, John, who both had intimate involvement in Alice's story. And the first step was to present these to stakeholders and get some input into the content. So we have revised scripts, or version 2 of the scripts. The next step is to turn those into what's called an animatic, which are static images that are put together like a storyboard. So it plays like a video, but really it's a series of static images with which are black and white and have some basic voiceover in a crude way. So these are the first kind of visual representation. And as I said, there were 3 videos that were being developed. So we had 3 of these. So that's a crude video. The next step with further input is to develop we're calling here a draft animation, which now has color, it has movement, and it has a better voiceover, but it's not the final version, but it's meant to be near final. And I'll show you an example of that later. And then with the final round of input, we end up with the final animations that in fact are not ready yet, have been somewhat delayed by the whole pandemic situation. So that's the overall process of developing videos. the way that the various stakeholders were involved was, first of all, family members were involved throughout the whole process. So they, as I said, developed the initial scripts, and in every cycle of input that occurred for each of these steps, they were the final arbiter of what changes were made. So they were, if you will, the caretakers of the whole process. The main reason for that was to make sure that the story and all of the presentation remained true to Alice's experience and that they were comfortable with it. So they were involved throughout the whole process. Now, we mentioned two groups. So there's the Deprescribing Partnership, which I'm describing here as provider/system stakeholders, or Deprescribing Partnership. They were involved in the early stage of initially critiquing the scripts, and then critiquing the animatic version. We involved them early because we wanted input from healthcare stakeholders regarding the content to make sure that there would be a buy-in to the overall messaging and meaning of the videos, so that we wanted healthcare stakeholders to be willing to have their patients watch these, so we wanted their input early. Later on in the process, once we got to the stage where there was a visual representation, namely the animatics, that's when we got patient and caregivers involved. We thought it would be premature to involve them, and it would be hard for them to relate to simple written scripts, so we got them involved only at the stage when it was visual. And then we rely on them to carry the process through to the end. So that's an overview of how we involved stakeholders. The next couple of slides just give a little bit of detail for each of these. So going back to the role of Alice's family, the purpose was to find out, as I said, what would have saved Alice. So we asked them this very specific question. And this is what they used as the basis of writing the scripts. What do you wish you had known then that you know now that would have saved Alice? And I think Mary already alluded to some of that. But that was the starting point we asked them to use to kind of trigger their writing of the scripts. They decided to write the scripts in Alice's voice, just to make it more a direct communication from Alice about what she had learned, what they needed to learn. The key lessons were decided by Mary and John, her husband, to be grouped into 3 themes, which I'll show you later. And so that's how we ended up with developing 3 videos. And so, and as I said, they were the final arbiters of all the feedback from the other stakeholders. So quickly, in the interest of time, I'll just mention, this is what it says here about provider system stakeholders. That's the Deprescribing Partnership that I already mentioned. The patient and caregiver stakeholder that I mentioned, that that I need to dwell on a little bit. So as I said, the goal here was not only to provide input into the videos, but also there was a long-range goal, which was to expand this team that we named the Team Alice Elder Voices. It had begun earlier, as Bob had mentioned, but initially it was basically a small group, Mary and other like-minded people that she had come across in her travels presenting this. Some people who had similar experiences and had come forward. So it was an embryonic stage. But in order to expand the group, we decided to use this project. And so in the process of recruiting people to help us improve these videos, we were also recruiting them into the Elder Voices Network, with the goal that they would have a long-range role in multiple future projects. So we did this we recruited them from 3 senior centers. And one of the principles that we learned from others in this domain was to leverage an existing group. So at these senior centers, they 2 out of the 3 of them had an AARP Aging Mastery Program, which was a group of seniors that were already meeting on a regular basis. So which provided an opportunity to piggyback this with a group that was already had some infrastructure and some regular meetings. The 3rd senior center had an exercise group that also had provided the same opportunity. So we engaged these groups, and the schematic earlier, you saw how the development of the videos progressed from scripts through to animatics through to draft videos. We're at the stage where the draft videos have been critiqued by the senior centers and the final edits are ready to go, but have yet to be finalized by Alice's family and conveyed to the to the animator to make them final, but that's the stage that we're at. So this is what I'm calling here preliminary results, just a little bit of a summary of what happened. So you can see here, I'm looking at the clock, seeing that I need to go faster. So you see we had significant participation at the senior centers. Most of the participants, I say 2 rounds of involvement at the senior centers where they reviewed the animatic and then the draft videos and gave input at each stage. Most of the participants were the same in both cases, in both rounds, because of that continuity from the pre-existing group. Input that was incorporated, this is a prompt to remind me to give you some examples. So the types of input we got from the stakeholders was quite varied, but extremely helpful and really had a significant influence on the messaging. One example was for the way in which Alice was portrayed was viewed by some as being too passive, and that even though she maybe talked about doing some things to advocate for herself, they wanted to see more imagery to go along with that, to illustrate her being active and advocating for herself, and they wanted to know more examples of how they could advocate for themselves. So that was an important type of content input. There were other types of input around how individuals were being portrayed, about, for example, racial diversity in the imagery, and about individuals appearing to be frail, where they would rather have individuals appear to be strong and able to advocate for themselves and take care of themselves. So those are important things that we were able to incorporate into the video. So that was actually extremely important and valuable. I can share more details about that in the Q&A if we have time later. I do want to show you quickly an extract from one of the videos. So let me quickly shift over. It will just take me a moment. This also gives me the opportunity to tell you in more detail about the 3 videos. So the 3 themes that came up, and you can see how they relate to Alice's story. So first of all, beware of new medications. Your life depends on it. This is directly from the experience that Alice had being prescribed cyclobenzaprine when in fact she probably didn't need it, and certainly was not safe for her, but there certainly were non-pharmacological alternatives, for example. So this video discusses those kinds of things. Beware of never meds. Well, Mary was told never to take cyclobenzaprine. So Alice was told rather, and what neither Alice nor Mary realized at the time was that by the neurologist telling them that that information didn't go anywhere else, right? No one else paid attention to that advice because no one else had access to it, and the other providers in the other locations where Alice was cared for didn't have that knowledge or insight to realize that cyclobenzaprine was risky for her. So this idea that the provider might tell a patient, never take this medication, this video talks about how patients and their caregivers can arm themselves with that information and advocate to make sure that they never get put back on that medication in the future. And then the video I'm going to show you a quick extract from is this one. It's about medications in the hospital. And again, it reflects on Alice's experience of when she was inadvertently started on cyclobenzaprine in the hospital. So let me just start that.
Hi, I'm Alice. I'm here to tell you what you should know about medication when you are in the hospital. Like many people in their 80s, I'm very active and independent. I look forward to every day thinking about what I want to do. However, from time to time, I've been in the hospital over the years. I assumed that because I was in the hospital, they would have correct information about my medications. I didn't think I needed to keep an eye on it. Let's go.
I'm going to pause it there and just say that the first couple of minutes after this, it talks about general advice about what individuals should do when they're in the hospital. For example, bring your medication list, check and see what you're being given, keep an eye out for any new medication that you might not recognize. I just want to skip forward a couple of minutes to this part, which talks about another issue, which I think is really critical.
Fourth, be alert for new symptoms that could be warning signs of medication problems, especially symptoms that you have never had before. In my case, I was given a drug without me knowing that caused symptoms I had never had before. This caused symptoms like hallucinations, panic attacks, sudden loss of appetite or thirst, dizziness, falls, and infections while I was in the hospital. If this happens, you and your family need to think that new symptoms could be medication problems. It is important to ask questions. Talk to your doctor or someone in charge of your medications. Don't stop until someone proves to you that it is not a medication side effect. So remember, take charge. Bring medication and allergy list to the hospital. Know what the pills in the cup are for. Do the right patient check every time. New symptoms could be drug problems. When you get a bill in the mail, do you look at it carefully? Don't you think you should do the same with your medications? Your life may depend on you taking charge of your medications.
All right, we'll pause it there. So as you can see, it's Alice talking. She, all of what you heard her say are direct experiences from the story that that Mary shared. So we wanted to stay true to the details of the story. The alternative is to come up with a mishmash of lessons that one could put together and say, well, here's some lessons that seniors need, and that may have covered some additional things that we didn't put in here, and it would have probably missed some things, right? But our approach was to say we need to take the lesson specific from Alice's story and have people hear from her as an individual, basing on the power of a story and the power of an individual person's experience. There may be other medication safety lessons that we need to share at other times, and we'll tackle those at another time. So, and all the three videos have the same basic idea of Alice telling her story and emphasizing different lessons and then a summary at the end. So that's the basic idea. The next steps are to finalize the videos. We want to try to test them, and we want to continue this stakeholder engagement process, which will guide us throughout the rest of this. So figuring out what's the best way to share these videos. When should people watch them? How should they watch them? How should they be shared? What type of feedback can we get on the impact of these videos? These are things that we have to figure out together with the stakeholders. So I apologize for taking up so much time, Bob. I'm handing it back to you to talk about the other type of stakeholder. Thank you.
Okay. Well, we're from New York, so we talk fast. So I will try to move quickly through this. So I think we've hammered the point home that Alice's neurologist was kind of the hero, identified the inappropriate drug, but was unable to, and we like to use this phrase, sustain the deprescribing. And that's part of what we're looking at within our systems. And unfortunately, the burden of sustaining this deprescribing was placed on Alice and Mary, but the system basically worked against them. Through our work so far, some of our pilot work and literature that we've reviewed, we certainly have identified that there are patient, provider, and system barriers. So as we've gone through it and put all this information together, what we realized is that we needed to have representatives from all parts of the system to work with. This idea blossomed as we were identifying all of these barriers that, well, why don't we get all these folks together? The barriers at the communication level between the pharmacy and the physician, or the physician and the patient, or bring in health plans. Could they be part of it? Bring in different other things. So that's what we set out to do. That's why we needed to do this. So when we talk about what is it, it's an advisory collaborative on our mission of education, research, and advocacy. It's made up of healthcare providers, and again, it's not just physicians and pharmacists. We have nurse practitioners, PAs, nurses. We have individuals from the academic world, including some of our research fellows. We have people from public health who are involved. We have economics, we have engineering. So we're trying to bring all of these points of view together and where we think. So if you think of the ideal deprescribing, you see an issue, the drug is discontinued, the patient knows it, the pharmacy knows it, the health plan knows it, all other interconnecting systems, including health systems, including specialists, everybody would know that that drug is deprescribed. I think most of us can think of the different work settings that we're in and realize, yeah, maybe we hit a few of these, but we don't hit all of these. So that's why we wanted to bring in all those areas. And they represent not only primary care, but we got long-term care, home health care, we have health plans, we have our local regional health information organization, as well as local foundations. As we realized as we were doing this that we might need some funding for some of these things, so we invited them as well. Okay, one back. Okay. So what were we trying to do this? So we were trying to partner to do a number of things. And we talk about identifying measures and outcomes of importance. And if we think all of this through, providers may have one set of outcomes that are important to them. Sometimes those are driven by healthcare plans. But sometimes providers will have outcomes that they want that are important regardless of what the healthcare plan wants. We always have to contrast this. This is why we showed that overlap before. So not only do providers, healthcare plans, they have their outcomes of importance, whether it's driving down Beers criteria drugs or falls related drugs, whatever that might be. But what about the patient? And that's why we like the way that we have our stakeholders set up, is that we hear from both and can kind of merge those outcomes together. Other things that we've partnered to do is designing pragmatic studies of deprescribing. And the one other benefit that we have of this partnership is that they end up then being our sites. We want to do these pragmatic studies. We want to learn and implement in a real world situation. So these sites allow us to do so, and I'll give you an example of that in just a moment. The other thing that we actually didn't plan on when we brought this group together was that they're learning from each other. The health plans are learning from the RIO. The RIO is learning a lot about, a prescriber could say, well, I discontinued this drug in my EMR. It didn't get to the pharmacy level, or it didn't get to the specialist or the health system level. So the RIOs are starting to understand that just because it's done in a EHR in one provider's office doesn't mean that message is sent out. And those are some of the things that again, they're learning about. We're learning about from them as well. So the example that I want to give you is a project. So basically through our interactions that we've had with our partnership, some groups felt that they did a really great job with deprescribing, while others admitted that they had struggles. What we wanted to learn about the deprescribing practices that are effective and then those that are not, and we want to match them with quantitative data on actual medication use. So we proposed this to a pilot group that we wanted to work with. And they basically came back to us and said, hey, that's a great idea, but we really don't want another researcher in the exam room. What about a video recording of the interaction? They want to use the videos for internal QA as well. And I remember sitting in that meeting and my head reeling going, oh my God, this protocol that we brought together is falling apart. And it was nice that during the meeting it kind of turned going, wait a minute, this is a huge opportunity. This research technique, it will allow us to better utilize our study team's personnel and eliminate a potential influencing factor. Also, it was nice to, this all occurred before the pandemic, and we now realize it's like, oh, this might benefit us a lot. We don't have to inject any other personnel into a primary care practice if we use this video concept. So they also brought another concept to our protocol that in healthcare decision-making, both by providers and by patients, those are often influenced more by emotions and experiences and not so much data. Many of us are data-driven, but there's emotions and experiences. So we're also incorporating collecting, this qualitative behavioral data in the protocol. And then finally, what Team Alice brought was our work in human factors and cognitive work analysis. We're looking at adding a formative evaluation of the deprescribing work, what is actually done, from identifying it to actually discontinuing the drug, what is actually done. So that includes identifying the knowledge required, the information needs, and the thought processes that health providers need in that decision-making process. So that gives us an overview between what Ranjit and I were talking about with the different projects that we're working on. But I want to give this back to Mary, and she'll finish today's presentation with her observations about our activities.
Thanks, Bob. This was Mom at 25 and how she thought of herself right until the end. She certainly embraced the philosophy that aging is not a disease, it's a victory. Thank you again for your participation in today's webinar. I'm confident that through research, interprofessional education, and advocacy, there is now greater awareness of the importance of deprescribing. Sharing Mom's story with change agents such as each and every one of you gives me great hope that patients, such as my mother, will be safer, healthier, and empowered to advocate for themselves when receiving health care services. Thank you all very much.
Well, this is Ken Bookvar. Thank you to Mary, Bob, and Ranjit for their presentations. I'm going to moderate a question and answer session, but before I do, I'm going to introduce a discussant. But please enter your questions into the Q&A using the Q&A button or the chat button on the bottom of your screen, and you can start thinking about those now. I wanted to introduce Catherine Sarkissian. Dr. Sarkissian is a professor at UCLA Division of Geriatrics, also in the VA system, and she's the co-leader of the U.S. Deprescribing Research Network's stakeholder core, and so we welcome her perspective on this presentation.
Thanks, Ken, and thank you so much to our speakers today. This was really an inspirational presentation, and I would say this is really the gold standard of stakeholder engaged partnered research. So to those of you, we get, through our stakeholder engagement core, which I have the opportunity to co-direct with Dr. Nikki Brandt, we get a lot of questions from scientists who've never done stakeholder engagement before research. And so I want to highlight three main themes. I mean, there was so much in your presentation, but three things for those of you out there who are thinking about just starting to do stakeholder engagement research that I really heard, which is making your work so successful. Number one, you have a very, very diverse group of stakeholders. So, we just went through our first pilot round. Sometimes we'll have an application that'll come with just patients or just caregivers, but you have the family, the patients, the caregivers, the health system leaders, the funders. There's clearly so much thought into the diverse group of stakeholders you have. Secondly, you tried to adhere to the principles of community-based participatory research as much as you possibly could, and that was evidenced as you involved your stakeholders through every single phase of the work. One thing we hear from stakeholders all the time, there's nothing that drives them more nuts, and I completely understand, is when someone completes the entire research project and then goes at the end to ask the stakeholders what they thought. But you were the opposite of that. You had the stakeholders absolutely from the get-go. Thirdly, Dr. Singh, I thought you made a really good point, especially for beginning scientists who may be on a small budget, which is you leveraged existing groups. You went into the senior center and used aging mastery program groups, I think, and AARP groups, but I think that's really great advice for the junior faculty out there as you're starting to think about doing your projects on a budget in a way that respects the stakeholder voice, is to find those opportunities to leverage what's already out there. So thank you very, very much, and I'll leave the rest of the time for questions.
Great, thanks, Catherine. So again, question and answers. Questions can be typed into the Q&A box at the bottom.
If no one has questions, I have questions, but I wanted to open it to the group.
Go ahead. Why don't you go ahead and ask your question? Oh,
okay. Well, I'm so impressed how you have 25 partners in Western New York of these diverse stakeholders. What's in it for them? How do you get them to come? I mean, if you have a big grant, you can pay people, but when you're just starting out, how do you incentivize this diverse group to come to the table?
We only give them food, and occasionally Bob buys wine, but otherwise they're there because they care, right? I mean, and to me, that's what's most impressive about it, is that what's in it for them, I think, is they can feel as though they're part of something that might help solve the problem, right? And so they feel as though they're part of something larger. They have the opportunity to talk about it. You know, some of the time spent in the groups is people commiserating about how bad things are and how things got messed up with their patients' medications and the challenges they're facing trying to reconcile medications and avoid problems. But so they become part of maybe a peer support group in some ways. But then we try to focus the discussion around, okay, what are we going to do about it, and what resources can we all bring? And because they're a diverse group, they all bring different skills and resources. We have people there from the health plans, from the health information exchange, and then practitioners. And they can get to hear, oh, okay, someone from the payer is really listening and trying to understand what challenges we're facing. And the health information exchange people are here. And so maybe there's something that they can do to help, et cetera. So I think that's what they get out of it, right? Bob, do you want to add anything?
Yeah, I think, and I apologize for my next door neighbor's lawnmower. But one of the things that we did is we strategically identified who are really the important individuals within Western New York when it comes to health plans, when it comes to big practices, things along those lines. But a lot of it has been kind of personal outreach. You know, many of the pharmacists, I've been at UB School of Pharmacy long enough now, many of the pharmacists are my former students or guys that I've worked with, you know, over the years. And Ranjit's done some similar things with, you know, reaching out to individuals that he's worked with over the years, and you know, just that personal outreach sometimes is what you need. It's like, you know, I can give the 30-minute or 30-second elevator speech about how bad deprescribing can be and say, could you come along with me? You've got to practice. Obviously, you know, Western New York, we do have an older population. You know, obviously you see older patients. Don't you see this problem? Why don't you come? So I think that personal part is important as well.
Thank you so much.
Great, thanks. We do have a question from Kathy Frank. Any thoughts about how to improve medication accuracy during transitions between nursing homes, ED, hospital admissions, and then back to the nursing home?
I wonder if Mary wants to talk about this from her experience. Do you want to talk about it? Because I've heard you talk about this before, Mary. One simple strategy.
Well, I think, you know, communication is a key that was lacking, certainly in Mom's case. There, you know, just the basic communication between providers, between parts of a team. You know, we talk about, you know, Team Alice as being a team. Well, it really also has to happen between providers at the bedside as well, and then also with the handoff from then that transition of care from, for example, you know, a community hospital to a rehab facility, being able to actually, you know, articulate and communicate, as well as encouraging patients and family members to have the same, you know, level of communication and question.
So when I think of this question, the first thing that comes to mind is technology, and I think that's what most people think of. But we need better electronic communication and gadgets and stuff, and we think, okay, if we had better technology to share the information, it would work. But what Mary's pointing out, which is why I wanted her to say it, is from a layperson's perspective, is that it's actually the talking that probably, you know, actually talking to the patient and the family member about what are you actually taking that actually makes a difference. And that's what a true medication reconciliation is supposed to be. But I think that we mostly tend to have technology trying to do the medrec for us, and we go into the EMR and we see the med list auto-populated that somehow got there from someone, somewhere, somehow, and we just trust that. And we don't actually talk to the patient or the family or whoever's in charge of the medication. So.
And just, I know we're short on time, but just one of the reasons we have the Rio involved with us was Ranjit and I sat on a panel with them when they wanted to do a better job of med reconciliation, and we just sat there and pointed out all of the flaws. They thought technology could save everything, and we're like, well, no, if this human doesn't do their job well, it doesn't matter what the technology does. So I think that was kind of an eye-opener to them, and one of the reasons that they're participating with us is that, you know, I look at the tech part as kind of being the safety net. Yes, the communication needs to be there, but the tech needs to be there to be that back-end safety net to prevent a human from failing to do what they're supposed to do.
Great. We're going to hold questions at this point because we're at the top of the hour. And I will turn it back to Jen.
Great. Well, this has been just inspiring and reminds us all about why we do this work. So thank you all for your work, and thanks for doing this. So I want to thank you all for attending today's webinar, and especially our presenters, Dr. Sarkisian, for summarizing the discussion and how to do stakeholder engagement, at least how to start to think about it. A recording of the webinar will be posted on the US Deprescribing Research Network website. And you will also, once the webinar ends shortly, you will be receiving a survey link to provide us with your feedback. So please fill that out and help us make this even better than we can. So thank you all and have a great day.
Thank you.
Thank you. Bye-bye.
Thank you. Bye.
Bye-bye.